Hello all, welcome to PharmaNandan. In this video, we are going to discuss pharmacology of migraine. So what is migraine? Migraine is, we all know it is a type of headache, right? And headache is based upon exogenous cause. It is classified into two types. That is, when we know the exogenous cause, when we don't know the exogenous cause, headache is classified. For example, if we don't know the exogenous cause, that is, if there is absence of any exogenous cause, we call it as primary headache. And if a headache has very well defined presence of any exogenous cause, then we call it as secondary headache. How it is pharmacologically relevant? Because for secondary headaches, usually we look after treating the cause. Treat the cause. For primary headache, what is the thing? There is absence of exogenous cause, right? So we will look after what is the receptor affected in this primary headache, and we try to solve the issue on focusing on the receptor. What are the types of primary headache? Mainly three types of primary headaches are there. Under which category migraine comes? That is most common. Migraine is the second most common primary headache. What is the first most common primary headache? We all know, we call it as tension type headache. What is the third most common primary headache? We call them as trigeminal autonomic cephalalgias. It is a group of headaches among which there is a popular headache which we all know. Most popular one is among trigeminal autonomic cephalalgias is cluster headache. So the coming to the clinical features of the migraine, what is the main thing which is present in the migraine? Yeah, we all know headache is present, but along with headache, there are some specific features in migraine. We call them as pre-aural symptoms. That is migraine with aura. With aura, what is the aura? In migraine patients, they have more sensitivity to sound. They can't tolerate sound, they can't tolerate light, and they can't tolerate even movement. What is movement? That is, they can't even travel in some basic vehicle like car or jeep, anything. If they travel for a while, they are highly sensitive and they will get attack of migraine. They're sensitive. One more thing which is associated with migraine is nausea, vomiting. And before the attack of headache, all these symptoms may appear in the patient few hours or few days also before the attack of migraine. We call them as migraine with aura. In some patients, there may not be no aura. We call it as migraine without aura. So, where is the site of pathology in migraine? Where is the main problem happening in the migraine? So, first to discuss what is the site of pathology. Where is pathology lying? Because it is a primary headache, we need to focus on the receptor. We have to treat the receptor, right? So, where are those receptors present? That is, we have to go and get target them: brainstem and hypothalamus. These are the main sites of pathophysiology of migraine. Okay, what happens in migraine patients? First thing we should observe is, in migraine patients, the dopamine receptors in these migraine patients become highly sensitive. We call them as hypersensitive when compared to non-migraine healthy patient. So what is the clinical feature because of dopamine receptor hypersensitivity in migraine patients? We see yawning, and this nausea vomiting is also due to hypersensitivity of dopamine. And the main site, other main site, important site of migraine pathophysiology is trigeminal nucleus. What is the problem with this trigeminal nucleus in migraine patients? When this trigeminal nucleus is activated, there is release of calcitonin gene related peptide. Okay, along with the CGRP, substance P is also released. Where these are released in the from the trigeminal nucleus, they are released at the same nerve endings. What happens then? At these nerve endings, there are blood vessels, that is arterioles, venules, and the anastomosis of arterioles and venules, arteries, all the vascular system of the brain which are present near to these nerve endings. These come into contact with the blood vessels. What happens when these blood vessels are stimulated? There will be vasodilation, which causes headache in the patient. Okay, due to blood vessel dilation, it causes headache. Then how it is tackled? In the blood vessels, we know there are serotonin receptors of subtype 1b and 1d. Okay, these blood vessels, what is the role of these receptors in the blood vessels? When these are stimulated, when agonist acts on it, same process happens, but in the opposite direction and under different receptor. That is, when these are stimulated, there will be vasoconstriction, which causes relief of migraine. Okay, it relieves migraine. So in a nutshell, we can see that there is dopamine receptor which is acting as villain here, and the trigeminal nucleus which is releasing CGRP. These two are the main thing which are causing migraine headache, and these receptors is helping the patient if there is any agonist to it, that is, it is pulling towards the treatment. These two are pulling towards the migraine worsening symptoms. We can compare it to this picture, right? CGRP attacking the brain. Here we can see CGRP attacking the brain, and dopamine is also attacking the brain. And who is protecting here? This serotonin 1b and 1d receptors are trying to save it. That is, when these are stimulated, when we give strength to this one, agonist is there, there will be relief of migraine. It is fighting with CGRP and dopamine. These are on one side and this is on one side. So the treatment of migraine we can understand by now. We have to give serotonin 1b 1d agonist and CGRP antagonist, dopamine receptor antagonist. Agreed? So what is the treatment of the migraine? So migraine, when I told you, it is a thing which is depending upon the personality also, right? The mainstay treatment is non-pharmacological actually, but we give pharmacological therapy as a supportive therapy. We call it as adjunctive therapy when there is no symptom relief. So what are the things which we give pharmacologically? First choice, immediately we don't go to higher end drugs. First we try with NSAIDs. Okay, and when there is no relief, when it is mild migraine, NSAIDs will help a lot. When the migraine worsens to moderate or severe level, then we have to think of serotonin 1b or 1d agonists. Okay, there is a group of drugs, we call them as triptans, and ergoalkaloids like ergotamine, dihydroergotamine also come under the serotonin 1b 1d agonist. What is the third group of drug? We discussed already, CGRP antagonists. These are grouped together as we call them as GPANs. And another group of drugs is, there is one special receptor of serotonin. We call it as serotonin 1F type of receptor. For this receptor, when we give agonist, there will be relief of migraine. We group these drugs are ditans. And another drug we discussed earlier, dopamine receptors are causing migraine, right? So we should block these dopamine receptors. We call them as dopamine receptor antagonists. So coming to the mild migraine, when the migraine is mild, no need of high-end medications, we give NSAIDs, right? What are the NSAIDs we give in migraine? Number one, we all know Paracetamol, yes, most common drug. And after paracetamol, most common thing is aspirin and naproxen. It is very popular for migraine. And naproxen, ibuprofen is also used. Diclofenac tablets are also used, and tolfenamic acid, it is also used. So what is the main thing which we should remember about these NSAIDs? These NSAIDs are most effective when taken early. That too in, it works only in mild case of migraine attacks. Next line, when mild migraine, okay, we had no insights. When the migraine is a moderate or severe level, then what should we give? Yes, serotonin 1B and 1D agonists, right? What come under these drugs? We know ergotamine, dihydroergotamine. These works very greatly for migraine. We give them as injection, or we can give them as oral or injection, or these are available as nasal spray also. So what is the problem with this ergotamine, dihydroergotamine? They give a very great relief for migraine, but these two are highly emetic. So they cause side effect as vomiting. So that's why before giving ergotamine, dihydroergotamine, we need to think about side effect, and we have to treat appropriately, right? Other serotonin 1B, 1D agonists, we know these come under the group of triptans. And coming to the triptans, the important point is, we discussed already, in the migraine headache, this is headache phase. Before headache, there will be some symptoms which patient can feel. We call them as aura, migraine with aura, right? When aura is completed, when a headache is about to start, at this point, exactly at this point, triptan should be given. Then it works the best. Just after the immediately after the onset of headache. When triptans are given during the oral phase, it may not help the patient very well. So ideal time to give triptans is just after the onset of migraine headache. So what are the examples of triptans? Very popular triptan, sumatriptan. This is available as tablet, and this is available as nasal spray. It is available as nasal spray, and it is available as needle free device also. And all the triptans generally are not indicated for cluster type of headache. Cluster headache, these are recommended for migraine headache. But sumatriptan has US FDA approved indication for cluster type of headache also. Other triptans, they are not approved for the indication of cluster type of headache. And what are the other triptans? Zolmitriptan. What is the important thing which we should remember about zolmitriptan? It is also available as nasal spray along with oral tablet form. Okay. Next triptan is naratriptan. Next triptan is rizatriptan. And rizatriptan is available as orally disintegrated, orally dispersible tablets. That is, no need to put water. Okay, we can take tablet into the mouth, it will dissolve automatically, easily. Orally dispersible tablet, this rizatriptan. And it is having, as per studies, most efficacious triptan is rizatriptan. Another thing is also there which we'll study later. And another triptan is frovatriptan. Next triptan is almotriptan. For almotriptan, we need to remember one more point. We know it is acting as agonist on serotonin 1b 1d receptor, right? Along with 1b and 1d, it also acts as agonist of 1f type of receptor also, almotriptan. Okay, and last triptan, that is latest triptan as per available triptans in the market, is elatriptan. What is the special feature of elatriptan? Same thing like almotriptan. It is agonist as it is an agonist on one serotonin 1b, serotonin 1d, and serotonin 1f also. I told you rizatriptan is most efficacious, right? And elatriptan is also equally efficacious as rizatriptan. Both are equally efficacious and both are having highest efficacy when compared to all other triptans. Okay, and one more thing we should remember about the triptan is a triptan when you give to a migraine patient, it should give, or let me erase it. Triptan when you give to a migraine patient, patient should feel relief within 1 hour. Okay, when there is no relief in the patient for 1 hour even after taking the triptan, it means that triptan is not working in that patient, or the dose is not suitable to that patient. So relief should be within 1 hour. If not, in the subsequent attack, we should change the drug, or we should, or if we don't like to change the drug, we should increase the dose during subsequent attack. If there is no relief within 1 hour, relief should be there within 1 hour. Okay, and the caution with triptans is, what is the main thing which is to be remembered with respect to triptan? Triptans, I told you, it causes vasoconstriction, right? It constricts vessels, blood vessels, right? It automatically constricts the vessels in other parts also. So we should be very cautious. We should take a caution when triptans are given in coronary artery disease patient and peripheral artery disease patients also. We should take care of caution in these patients. And coming to the incidence of vomiting, I told you ergo compounds are very popular for nausea, vomiting, right? So when we compare triptans and ergo compounds as a side effect which are causing nausea, ergo compounds, ergotamine and dihydroergotamine, they cause nausea, vomiting more than triptans. And coming to the incidence of recurrence of headache, here in this case, coming to the recurrence of headaches, triptans are better than ergotamine. Okay, that is, triptans will cause more recurrence of headache. Those are not better. Ergo compounds are better. Triptans will cause more and more recurrence when compared to ergotamine and dihydroergotamine. And other group of drug is 5 serotonin 1F subtype agonist receptors. On those receptors, what is the example of these agonist? Lasmiditan. We told you they come under the group of ditans, right? Common example, latest example is lasmiditan. And regarding this serotonin 1,5 receptor, the location of these receptors are in the CNS and peripheral nerve and the peripheral nervous system. But these receptors are not present in blood vessels. This is the reason for this drug, no need of caution for this coronary artery disease, peripheral artery disease. Okay, these are safe in this condition. Okay, so they are safe in this condition, but there is a problem with this lasmiditan. It has a side effect of dizziness. To such a level, it is recommended that any person who takes this lasmiditan or these ditans for 8 hours after taking this vehicle, he should not drive the vehicle. Okay, don't drive for 8 hours after taking this lasmiditan. And what are CGRP antagonists? There are three CGRP antagonists in the market. First one is ubrogepant, and the second one is remigepant, which is becoming highly popular nowadays because it is recently approved in CDSCO in the around March 2025. This remigepant is available in market as 75 mg orally dispersible, orally dissolving tablets. And one more drug is there, zavegepant. It is available as nasal spray. This is how zavegepant looks like, nasal spray. And what are the dopamine receptor antagonists which are given in migraine patients? There are three dopamine receptor antagonists which are popular: metoclopramide, and chlorpromazine, and the third one is prochlorperazine. And before, for a migraine patients, they know when they're having recurrent attacks of migraine, right? That's why migraine patients also go for prophylaxis of migraine. That is, there are some group of drugs which are used for the prophylaxis of migraine. First thing is beta blockers. What are the most common beta blockers? Propranolol and metoprolol. And there are a group of antidepressants which are recommended in this migraine patient, so that there will be acting as prophylaxis for this migraine. What are those group of antidepressants? Number one is amitriptyline and dosulepin, nortriptyline, and venlafaxine. These are given. Some anticonvulsants are also given based upon the clinical status of the patient for migraine prophylaxis. What are those? Topiramate and valproic acid. And there is one special group of antagonist, serotonin type 2 antagonist, which is also acting as helpful for the prophylaxis of the migraine. It is actually not US FDA approved. It is used in other countries, pizotifen. And there are some monoclonal antibodies which are available in the market which help for the prophylaxis by acting on the directly on the CGRP molecule or on the CGRP receptor. Anything may happen, anything may occur for these monoclonal antibodies. What are those monoclonal antibodies? Erinumab and followed by fremanezumab, and the third one is galcanezumab, and the latest one is eptinezumab. There is a work going on biosimilars on these also. Eptinezumab is the latest one as of now. Thank you for listening, and for any queries, please feel free to mail us at pharmanandan at the rate of zohomail.in. For any suggestions or any improvements, please send an email to us or put it in comment box below. Thank you for watching.